what I'm going to show you are cool pictures. Cool pictures in regards to what we're doing for technology in the posterior fossa. And when they initially said, talk about all the tumors in the posterior fossa, I said, there are vestibular schwannomas, meningiomas, epidermoids. I could talk for like 4 hours. And they're like, you had 10 minutes. And so I'm really just going to focus on acoustic neuromas and focus on cool things for acoustic neuromas and try to make this at least entertaining, if not fun. So acoustic neuromas, we all know what they are in this room. We've been to multiple talks. They are along the facial and the cochlear nerve. And we know that radiosurgery is an option. Okay, I went to the acoustic neuroma session this morning. I went to the one in the afternoon. I'm just saying radiation is an option. I'm not saying it's better. I'm just saying it's an option. And I'm not even saying it always works either. It fails. Yes, we all do. Okay, and surgery fails too sometimes. I'm just saying it's an option. It's absolutely clearly an option. So if there's a 65-year-old patient who comes in with an acoustic neuroma, radiosurgery should clearly be an option. But the question in terms of radiosurgery, and I really liked how Dr. Morkos and everyone was talking about how we're expanding skull-based surgery because it's expanding into radiation oncology as well, is how do we do this radiosurgery for acoustic neuromas? And in terms of acoustic neuroma, we know that radiosurgery saves hearing. It has good hearing preservation. But it does something even better than that. It does fantastic facial nerve preservation. Okay, and we see these giants operate, and they're like, in my hands, I have this kind of facial nerve preservation. Well, I'm standing up here and saying, in my hands are probably not as good as Dr. Spetzler's or Dr. Morkos, and I'm just telling you, right? And you probably already knew that about me, okay? Well, I'm here telling you, my hands are not as good as Dr. Morkos, you know? His hands are better than mine. But I do my best. It is what I can do. I can do my best. I forget the rest. Okay, and so I'm going to do my best for my patients, but radiosurgery has outstanding facial nerve preservation. This is one of my papers, and doing this large meta-analysis, it had a 96% plus chance of facial nerve preservation. And at UCLA, that number is even higher. And so it does a really good job of facial preservation. I want to put that out there as a realistic thing. And then, if it has excellent hearing preservation and even better facial nerve preservation, like Oren was commenting on, is how much of the tumor do we need to take out? How much of the tumor? And people are always saying that I'm arguing for subtotal resection. I'm not arguing for subtotal resection. I'm arguing for safe surgery. Safe surgery. And that we did this analysis in the modern era. If you have radiosurgery as a backup to surgical resection, does subtotal resection, near total resection, or gross total resection make a big impact on overall survival and progression-free survival? And I know, we see the talks, right? We all come up here and go, look how big this tumor is, and it's all gone, right? We all show our trophy cases, and we all show our radiosurgical horror cases. We radiate it, and the tumor comes back, and it's really bad. But we're looking at overall numbers. If you look at the overall numbers, if you look at the average patients treated, in the long terms, it doesn't make a huge difference. But what we're trying to do is the best and safest maximal resection. So this is where the cool pictures for me come in. So for me, I want to get a gross total resection. But when I do a gross total resection, my risk for facial nerve injury goes up. Maybe yours doesn't, but mine does. Okay, the more I resect, my risk of at least a temporary facial palsy, it goes up. Now, if I leave a lot of tumor, I don't like it. Can I just tell you, emotionally, I don't like it. And I always want to take out more. For me, I tell my wife that I feel like I'm Homer in the Odyssey, where they have to strap me to the mast of my ship, and I hear the siren call. And for me, the siren call is surgery. And to hear from me, the siren call is take out more tumor, take out more tumor. And I just want to keep taking tumor out, but really there has to be a point. But subtotal resection could be safer for the facial nerve. And so what I want to do is minimize this risk. Well, one thing that a lot of people do now, and there are a lot of companies that I have no disclosure with, like Synaptive, that do this tractography, white matter tractography. Well, what we wanted to look at UCLA was, could this be done on facial nerve, for facial nerve tractography? And so we looked at 38 cases, a range of 19 to 70 years old. Yes, that means I operate on an acoustic neuroma on a 70-year-old. And we looked at these patients to see if we could do the facial tractography, and indeed we could. about 95% of the time, we can do facial tractography. And when I say we, I'm using the royal we. It's like my postdoctoral fellow, my research people who are spending hours doing this, and some of them are in the room. And so we can do this and do tractography for the facial nerve. And then, is it accurate? When we go into surgery, we find that about 90% of the time, it is indeed accurate. These are my cases, so it says that the nerve is inferior and down. 90% of the time, it's accurate. So 95% of the time, I can do facial tractography. 90% of the times, it's accurate. It makes really cool pictures, but does it make any clinical difference? These are my numbers here. I have an 85% chance of a grade 1 or grade 2 immediately in the first 6 months, and I have about a 16% chance of some facial weakness in the first 6 months after surgery. So it's a really cool technology. It's incredibly labor intensive, and these are the images we get. So you can see here that the tumor is wrapped in purple, and we're the official, UCLA Health is the official doctors for the LA Lakers, and so we have these colors. And the nerve is in yellow, and here you can see the facial nerve and the 7-8 complex draped right where it's supposed to be, on the anterior portion. So for this patient, it worked out really well, and it creates these really awesome pictures. It helps with the brain lab navigation. We use brain lab navigation as well. I can know where the nerve is before surgery, but does it make the surgery safer? I don't know. I haven't clinically proven that, but it's a really cool picture, and this is where we're trying to push the boundaries. And so our data suggests that DTI imaging and tractography can be done as a reliable preoperative planning tool for acoustic neuromas. And I think that this allows for better, at least anatomical preservation, if not functional preservation. We also looked at the tumors that we treat at UCLA with radiosurgery and radiotherapy. We compared the group of radiotherapy versus radiosurgery. And in the afternoon session, Dr. Porter from the Barrow went up and said that radiotherapy had better hearing preservation than single dose. And our data at UCLA found the same thing, that radiotherapy had a higher association with hearing preservation. And so that if you treated people with fractionated radiotherapy, and when we talk about radiotherapy at UCLA, this is 28 fractions, 5.5 weeks. This is not convenient. Okay, this is not, I tell my patients, this isn't convenient, but we think it's better for hearing preservation. So you come 28 times and you get 50.4 gray versus coming one time and getting 12 gray. You have a hearing preservation that goes from about 60% in single dose radiosurgery to upwards of 80 or 90%, and this is statistically significant. And we published this in the Journal of Neurosurgery. And this is the actual hearing preservation. And you know, my background is in glioma research, and so we just do these things except for hearing preservation. And what's really interesting is that benefit of hearing preservation from radiotherapy, it's real. It's statistically significant and it's real, but it only lasts for about 10 years. After 10 years, whether you do radiosurgery or radiotherapy, it seems that hearing beneficial effect of radiotherapy may become a wash. And so that's really interesting. Well, the next thing we wanted to do was ask, well, why? Why is radiotherapy better than radiosurgery for hearing preservation? And and again, that's the royal we, but really my postdoctoral research fellows and my residents and my medical students, we wanted to look at cochlear dose. So for all those 180 or 90 patients or so, they went back and contoured the cochlea. So how did they do this? And this, by the way, is tedious and is not trivial. It's a lot of hard work. So on every single one of these radiosurgical plans, they start here with the T2. Okay, we start here at the T2, and you can see here the cochlea because it's hyper intense on the T2 MRI, and that helps you identify it. Well, that's not enough because it's still confusing with the superior the semicircular canals, and so we fuse that with the CT scan, and on the CT scan, the cochlea you can't miss it. And so we do this to contour the cochlea and then go back and find out the dosages of the cochlea for radiosurgery. And what we found was that in radiosurgery, single dose, when the cochlear dose was above 8 gray, there was a significant increase in hearing loss. So that hearing preservation was better when you could keep the cochlear dose less than 8 gray. And you can see this on a dose volume histogram here, that looking at the curve in people with decreased hearing versus stable hearing, people who had stable hearing had lower doses to their cochlear apparatus. When you compare this to radiotherapy, the curves overlap. And so the mechanism here isn't clear, but our hypothesis and our postulation is that when you do that 28 fractions and you do those bite-sized doses, something about hitting the cochlea in 28 fractions of very low doses was better for hearing than hitting them in one dose for 12 gray. And so our modus operandi at UCLA has changed now so that if your hearing is intact, we're going to recommend fractionated radiotherapy. And for the young residents and the learners in the room, where you really want to take this is go, well, I don't believe you, Dr. Yan, I don't believe you, Isaac. You know, why 28 gray? How come why not 27 fractions? Why not 20 fractions? Why not 5 fractions? Or if you're from Stanford, why not 3 fractions, right? You're going to ask me those numbers, and that's really the right question. Remember, they were asking and saying, you all need to be rebellious and questioning and rocking the boat. That's really the right way to go. Is there may be a better answer, and the better answer may be something like 5, 7, 8, something that's more convenient and has just as good numbers, and that's the future. The end goal, though, is to do no harm and to do personalized neurosurgery for every patient. And this is back to what Oren was talking about, was adaptive hybrid surgery, is when do you want to take out tumor? And it sounds good. Like when Oren talked about that, it sounds really, and he showed his example, I'm not going to take out all the tumor, I'm going to leave residual. And doesn't that sound great? Leave residual and do safer surgery. But the devil's in the details. How much residual is the right amount of residual? How much residual is the right amount of residual? And that's really the question that I tried to address with this study, which was surgical planning. If I got every single surgeon in this room and said, here's my acoustic neuroma, please draw me your ideal residual, how many of those plans do you think would be exactly the same? And it's not well identified. And so we did this study. These are my patients. This is a patient de-identifier. This is an acoustic neuroma. I did a retrosigmoid. It took me 8 hours. And then here you can see volumetrically, this is 100% of the tumor. Oh, this is coming out really poorly here. But you can see that these little 4 lines, these are different neurosurgeons. I took my cases, my acoustics, to neurosurgeons and asked them to contour an appropriate residual. And so this is what one neurosurgeon did, this is what another neurosurgeon did, and these are all the contours. And then the software said that if I left this much tumor, I had a radiosurgical target. So the software is saying this is how much I should leave, this is how much these 4 different neurosurgeons said I should leave, and then over here you'll see what I actually left, which was 8%. And like I said, I don't know when to stop. And this is what this contouring looked like. Here's the tumor. You can see this is the tumor before surgery. This is what the software said. If I could leave this tumor, this would be safe for single-dose radiosurgery. And then these are what 4 different neurosurgeons contoured to say this is your ideal residual. And you can see clearly all 4 are completely different. And we actually did this to 8 different neurosurgeons. So we had that data that every single person is contouring something different. And yet the computer is saying, this is the ideal resection. And I think that probably the ideal is somewhere around this. And I think this lecture is so much easier for me to give now than it was 3 or 4 years ago. Because if you would have asked yourself, would there be a self-driving car 15 years ago? You would say, no way, there's never going to be a self-driving car. And now we are on the verge of cars that drive themselves. And here, we won't have computers replacing surgeons, but we're having computers suggest to us, like big data or IBM, Google, who's going to say, you know what, this is a glioma, this is a meningioma, and they're going to be able to tell you how much of the tumor may be best for large populations in terms of overall resection. So we did this for this patient. I know I have just a few minutes left. We did this for several patients. These are all the data slides. We did this repeatedly, and these are the summarized results. Here's the tumor. Before surgery, it's always 100%. This is what four different surgeons said was ideal residual, volumetrically. The computer summarized at about 60%. Really, you only need to take out 40% in order to make this a good radiosurgical target. And then this is me. These are my cases that post-operatively, I averaged about 30% here volumetrically left because I took out more than we needed. And the difference here is perhaps this is less surgical time, less time under anesthesia, less risk of DVT. And if this patient's 60, 65 years old, these patients may do better if I take out less. That less, indeed, may possibly be more. I think the conclusion here is that ideal resection is really hard to identify. I think neurosurgeons need to know more about radiosurgical principles, that we understand how to do the appropriate resection. And I think in terms of leaving residuals, we need to understand that brainstem decompression is extremely important, and we need collaboration between neurosurgeons, ENT surgeons, and radiation oncologists to make the best kinds of treatments for our patient. Thank you so much for listening. I want to thank everyone at the UCLA Brain Tumor Program, all the funding for my research, and my mentor who got me interested in acoustic neuromas so many years ago. Thank you. Any questions? Yes, Dr. Chacon.
Very interesting. Can you do tractography of the cochlear nerve and perhaps calculate the dose of radiation to the cochlear nerve?
The problem is that the nerves are really small. And so sometimes we'll pick up the cochlear nerve in terms of the facial nerve. It's not as consistent. It really isn't. I mean, we were pretty happy with 90% plus efficacy. Well, we really lost it, and it's really ironic because it'd be most helpful in the large tumors, and in the large tumors, it had the highest rate of failure because the nerve gets flattened out and thinned out, and then we just lose it. And in that time, the computer or the algorithms go back to their natural pathways, and they'll say that the facial nerve is going straight through the tumor. And when it does that, I don't believe that. I just say that's a nerve failure. And so, strangely, when I need it the most, this facial tractography, and I think that's why clinically it's of limited use, although it makes really nice pictures. It's limited use because when the tumor is biggest, it fails the most. And when the tumor is small, like 1.5 centimeters, when I probably don't need it as much and I'll just visualize the nerve, it works really well. Yeah. Thank you so, oh yes, Dr. Kim.
What if you know that your cochlear dose will be low with the SRS?
Uh-huh.
Do you still recommend it?
No. So we were initially recommending radiotherapy. So the question was, if the cochlear dose is low with single dose, do I recommend radiotherapy? No. So that changed it. So before, if your hearing was intact, we had radiotherapy recommendation versus radiosurgery recommendation all the time. But now, if we can do a single dose and keep your cochlea less than 8 or 6 gray, and we heard that earlier this morning, it was less than 4 gray. If you do less than 4 gray, you're never going to do single dose. And so you have to be reasonable about it. I think the real number is somewhere between 6 or 8. If you can keep it less than 6 or 8, I would say, yeah, do the convenient one, do single dose. And what we're really pushing is right now, currently, we are into the 18 months of our study is we're now doing 5 fractions. So we have 1 gray, we have 28 gray, and we have about 24 patients now that are treated 5 gray, 5 fractions. And we just want to see if that can have the same outcomes in hearing preservations as the 28 fractions, because it's just so inconvenient to do that. Yeah, Oren.
So, Isaac, how do you know what your cochlear dose is going to be ahead of time? Are you modeling this by taking their MRI?
Yes. So we are now we now routinely contour the cochlea before radiosurgery. Not me. But we, and I have really good residents and postdoctoral fellows and medical students. All right, thank you so much.